Hello, everyone, and welcome to the Thrive series. We are about to get started with tonight's session. I want to welcome everyone, whether this is your first time attending the Thrive series or you've been with us many, many times. We're so happy to have you here. And we are so happy to have kicked off the 2023 Fall Thrive series last week, and we're looking forward to tonight and many more sessions throughout this fall. As you may know, the Thrive series is a collaboration between mHealth Fairview and the Masonic Cancer Center at the University of Minnesota. We are so proud to offer 6 sessions this fall. Again, today is the second session, so don't forget to mark your calendar and sign up for the remaining 4 sessions. You can also rewatch sessions on our website, which is z.umn.edu/Thrive series. Now, before we get started, I do just quickly want to introduce folks to the team behind the scenes here. Myself, my name is Alyssa Martinez-Huebner, and then tonight, Kaya Verich will be your hosts for the evening. And so you are welcome to say a little hello to us. Behind the scenes, we are also working with our colleagues, Holly, who is here as well tonight, and then Amna and Elsie are not with us tonight, but you'll catch them on some of the upcoming Thrive series. So tonight, we are absolutely delighted to hear from Alyssa. I'm going to turn things over to Kaya to help get us started.
Hi, thank you all so much for joining us tonight, and thank you, Alyssa, for getting us kicked off. Again, I'm as equally happy as Alyssa to be here and kick off the second series of our Thrive session this year. Tonight, we're going to hear from Alyssa Kne on cancer genetic testing, screening, and prevention. As a genetic counselor, Alyssa helps patients and their families navigate complex genetic information and decisions pertaining to cancer risk management. We are recording tonight's session as we do each session so that you can refer back to the recording on our website. Again, that was z.umn.edu/Thrive series. And we do edit every recording before we post it to ensure your privacy. Before we get started, take one more moment, please, to locate the mute and the chat buttons. During the presentation, please use that chat button or chat box to submit your comments and questions. And at the end, Alyssa will be available to answer those questions. And we also would invite you, per your preference, to unmute yourself and ask questions at the end. If you are a University of Minnesota employee or spouse participating in the University Employee Wellbeing Program, Alyssa will put a link in the chat shortly for you to complete the survey and mark your attendance today so you can earn your wellbeing points. All right, now I will let Alyssa take it away. Thanks so much, everyone.
Thank you. Just a little bit of background about me. So I'm originally from Minnesota. I live in South Minneapolis with my husband and my dog, and my specialty clinically is in oncology genetic counseling. So from an education background, I have a background in genetics, cell biology and development, as well as psychology. I went to graduate school at the University of Minnesota, specifically for genetic counseling. And then in practice, I meet with primarily adult patients in the oncology clinic. So it can be someone who's been diagnosed with a cancer who's been identified at potentially at risk for an inherited cancer syndrome, or their family members who may also be at risk. And so we have a lot of topics potentially to talk about today. We'll see how far we get or if there's areas that are of special interest, but I want to just talk a little bit about what is genetic counseling, specifically in the cancer specialty. What can you expect if you were to meet with a genetic counselor? What is genetic testing? Just a general overview of what that process looks like, as well as cancer risk management. So that involves assessing what is the risk for someone developing cancer, are there additional screening recommendations we can make, and how that impacts family members too. I'd like to start with a definition about genetic counseling, which is the process of helping people understand and adapt to the medical and psychological familial implications of genetic contributions to disease. So it's a mouthful and encompasses a lot of different specialties. So genetic counselors from their training can practice in a wide variety of specialties. Usually we're pretty specialized now. So for instance, I only see oncology patients, but our training is broad. For clinical, a lot of the common specialties are prenatal, pediatrics, cancer is a big one. Genetic counselors also work in industry, in public health, but I know today's focus is on that clinical patient-facing side. What's common across all of these clinical specialties is generally what we do, which is interpreting family and medical histories, providing education to patients and families about genetics, management, prevention, and then that counseling aspect too, which is promoting informed decision-making, providing resources for family and individuals. I know when someone's diagnosed with cancer, and with cancer being so common, there's so many questions that come up, not only from a treatment standpoint, but also thinking about how does this impact my family? Are my families at higher risk now for cancer? Is my sister, my children, are they at higher risk? Am I at higher risk for now another cancer? We know for most cancers, they aren't hereditary. For the vast majority of cancers, they're considered sporadic, which just means that we don't fully know why they happened. It's likely a combination of many factors. Random somatic genetic errors, so those are things that occur as we age. The biggest risk factor for cancer really being age. As we get older, that risk gets higher. Lifestyle, certain exposures. Bad sunburn is a good example of a risk factor then for a skin cancer. Where in our field and for genetic testing, it's really only about 5 to 10% of families that actually have an inherited genetic risk to develop cancer. And so for those families, there is maybe a single gene that we can identify through testing that can be passed on from parent to child, potentially increasing that risk for certain types of cancers. And then that 15 to 20%, we still just generally call familial. Those would be families where there's maybe more cancer than we would expect just by random chance, but we can't find a single genetic underlying answer. So it's probably a complex combination of many factors. We know most cancers are complex. It's environment, it's aging, it's random chance. It's many little small genetic changes that could be inherited or were maybe random. So the role for cancer genetic counseling is identifying those individuals who may be at a higher risk for cancer. For themselves, it may help with screening. It may help with targeted therapies if they have an active cancer diagnosis, and then for family members as well, being able to identify who else may be at a higher risk. I'm going to keep this brief, but I'd like to just give a little background on what is a gene, what are we talking about here. So at the cellular level, we all have 23 pairs of chromosomes. So you have a pair because one comes from your mom and one comes from your dad. And within those chromosomes are genes. So you can think of those as segments of the chromosome. And each gene is made up of those individual DNA letters. And those are the instructions. So those are the instructions for our body to create proteins. Proteins are the workers that go off in our body and in this case are providing protection from cancer or maybe repairing DNA damage. So proteins are good when they're working properly. But when someone has a genetic mutation or variant that impacts that instruction manual, impacts the ability of that protein to function, that's what we consider a harmful mutation that may increase then cancer risk in the world of cancer genetics. What that looks like even more specific, so if we get down to the gene level, you can think of a gene again as maybe a book. We're reading through that book for any spelling errors. In this case, at nucleotide number 3, there's supposed to be a letter G. Maybe for this patient, there's instead of T. And that T misspelling is enough to cause that protein to no longer function properly. Or it's enough for that instruction manual to be confusing to the cell. We can't read through it anymore. And that protein can no longer job. So that's what we're looking for in genetic testing are those misspellings. They might be a single letter like this. They could be an entire page missing from the book. They could be part of the letter is somewhere else, or it could be a whole sentence is missing. So those are considered those genetic mutations or variants. And when we think about cancer development, technically it's all genetic. So all cancers are genetic. It's caused by genetic changes that acquire within the cells. It's just that typically we are born with no genetic mutations that are predisposing to that risk. And it takes those multiple hits within a cell to accumulate over time, which is why age is the biggest risk factor developing most of those sporadic cancers. Or if you're born with an inherited germline mutation, you're already born with that first hit. So your cells already have that first mutation that then can more quickly lead to potentially a cancer. And then when we think about inheritance for these genes, most often they're inherited in what's considered a dominant pattern, which means if you were born with a mutation in one gene, there's a 50-50 likelihood that each of your children would potentially inherit that risk factor too. And that's because kids will get half of their DNA from their mom, half from dad. So then I included a second copy of that gene, which we're assuming is coming from the healthy parent. One common example that I know a lot of people have heard about is hereditary breast and ovarian cancer syndrome, and that's caused by the BRCA genes. And there's two of them. So there's BRCA1 and BRCA2. I know these were in the media a few years ago when Angelina Jolie had testing done. They're just the most common genetic cause for breast and ovarian cancer. So in this chart, just as an example, for most women, the lifetime risk for developing a breast cancer is about 12.5%. But with a BRCA mutation, having that mutation at birth, it increases that risk up to 60, even 80%. Same for ovarian cancer. It's normally a quite rare cancer, 1 to 2% lifetime risk for most women. With a BRCA mutation, that risk could be as high as 40%. And then there can be other cancer risks too, like prostate, pancreatic. Men can also develop breast cancer, melanoma, seen in some families too. We know there's more than just the BRCA genes. Those are just the most common genetic risk factors. Still rare to have a genetic risk like the BRCA genes, but there are many other genes as well that are involved in cancer development, cancer risk. So on these charts, what I tried to convey is the darkest bar on the bottom would be our general population risk. So for breast cancer, it's about 12%. The yellow would be those moderate risk genes. So those are genes that maybe increase the risk between 20 and 40%, where it's not the sole reason a cancer may happen later on, but it's certainly a contributing factor. And then the gray bar just shows that those higher risk genes have just a much more substantial risk at birth. I also just wanted to give an example that there are also rare cancer syndromes. So there are genes associated with many organ systems, many different types of cancers. So an example I included here is something called multiple endocrine neoplasia, and there are two types. So for instance, with MEN1, we typically see someone with pituitary adenomas, parathyroid problems, as well as pancreatic neuroendocrine tumors. And it might be something that we can give a clinical diagnosis if someone has that constellation of tumors. Or if I meet with someone who has some of these tumors, it starts to raise that red flag. Maybe this is MEN1 or MEN2, where we may see someone with a pheochromocytoma, which is a very rare tumor. Tends to be more hereditary than other cancers. Even up to half of the time, there is a genetic risk involved and can also be involved with other aggressive cancers like medullary thyroid cancer. And so that's caused by the RET gene. So there are other genes as well that can be associated with very specific hereditary syndromes. So who should do genetic counseling and testing? Oftentimes it's based on family history, multiple family members diagnosed with the same type of cancer, early onset diagnoses. So when we see younger ages of diagnosis, it just raises that question, what led to that cancer happening versus someone who's diagnosed at an older age, and just statistically, it's more likely to be random or sporadic. Certain types of cancers too, like I'd mentioned, those pheochromocytomas just tend to have more of a hereditary component to them, where we say in general, it's about 5 to 10% of cancers that are inherited, but for pheos, it could be up to 50%. For ovarian cancer, could be a quarter or even a third of the time. So there are some tumors that just tend to be a bit more inherited. And this is just to convey that there's a lot of different things that we see in an oncology clinic. So there are the more common cancers like breast, ovarian, uterine, colon that all have genetic testing available, but also rare tumors, colon polyps. So sometimes there are inherited risk factors to develop hundreds or thousands of colon polyps that we can test for. So there's a lot of a lot of potential indications to potentially see genetics. And then what to actually expect during an appointment. So a genetic counselor will review personal and family history. So oftentimes putting together a pedigree or family tree, providing education about the genetics and the testing that may be offered at that time. So again, if I was meeting with someone who looked like they may have multiple endocrine neoplasia, that's what we'll be talking about for most of the appointment. We've got testing options, potential screening recommendations. That's oftentimes once we get those test results back and have all the data available to say, if there is a genetic risk, what should we do about this? And then certainly the sources too. And then the process of genetic testing is usually two parts. Oftentimes, first time you meet with a genetic counselor, that involves the test selection, going through an informed consent, since there are pros and cons of doing testing. Insurance coverage is another big question that we get, and so that's something that we'll check first as well. And then a follow-up appointment typically to go over those results. So a big advancement, it was in about 2013 that we started offering panel testing. So there was actually a patent on the BRCA genes for quite some time, and that was lifted in 2013 and allowed for other laboratories to start doing these larger tests. So if you're somebody who did genetic testing 10, 20 years ago and it was for breast cancer, it may have just been for the BRCA genes, those BRCA1 and BRCA2 genes. But now we're more routinely testing for a panel of genes. So you can see here, it's an example of 11 gene panel, all associated with breast cancer. So this might be a test that we offer someone who was just diagnosed with breast cancer. And these are all genes that have clear medical management recommendations. So any result on this test has some sort of national guidelines backing what those next steps would be. Also to note is that there is overlap with other cancers, just like the BRCA genes. Especially once we get to the bottom of that list, there can be a lot of different cancers associated, even with genes primarily associated with breast. Here's an even bigger panel that I routinely offer. So this is considered a more multi-cancer panel. Here we have about 85 genes that we can test for associated with a wide variety of cancers. So in this case, it's not just primarily breast, we're talking about really all organ systems here. And this is something that I may offer for a family where there's many different types of cancers that don't really fit with a single clear genetic explanation. It might be somebody who is just curious and wants as much information as possible, and it's all from the same blood test. Maybe it's someone who doesn't know their family history, who was adopted or just has limited family history information that we can offer these larger, broader tests. Potential benefits of testing. I think the big one is potentially answering the why, if we can find what is that genetic risk that led to a cancer to form. Sometimes there's targeted treatments. That's been a big area lately with genetic testing, where I've been getting a lot more referrals now to meet with somebody who was just diagnosed with a breast cancer, a colon cancer, an ovarian cancer, where there might be first-line treatments or chemotherapies that are recommended, but maybe down the road there's other targeted therapies like PARP inhibitors, immunotherapies that are more specialized for a specific genetic makeup of the tumor as well as the individual. Surgical decisions as well, where we may be thinking about lumpectomy versus bilateral mastectomy for breast cancer. And that brings us to those future cancer risks. We're just estimating, what is that risk? Am I at a much higher risk that warrants the additional screening? Is there risk management options I should think about, like surgery potentially? And then certainly for family as well, where it doesn't just impact you, it impacts family members too, since a lot of these genes are inherited from someone's parent, and then children would potentially be at risk too. Things to consider though, when we are talking about doing genetic testing. So one piece that comes up a lot is genetic discrimination. We have laws in place currently that stop your health insurance plan, at least most health insurance plans, as well as most employers from using this information against you. And there certainly are a lot of limitations there. I think if it's a company of less than 15 employees, that's an exception. Military may have some exceptions too. But that's been a law in place since 2008. It's the Genetic Information Non-Discrimination Act. Where it doesn't provide protection is life insurance, long-term care, and disability. So that is something to consider when we're doing genetic testing, that if you're looking into one of those policies, they could potentially ask about pre-existing conditions that could include genetic. cost has become less of an issue with the price of testing coming down, but still with insurance coverage, there's a lot of people with high deductible plans, and even with insurance coverage, could be thousands of dollars out of pocket. And so that's something that we also want to take into consideration when we're doing testing. What is that financial burden? If someone's knowing they're going to meet their deductible that year, it might be reasonable then to pay that amount. For someone who's met the deductible, it could be $0 out of pocket. Without insurance coverage, there are some commercial laboratories that offer reduced pricing options, even for those larger panel options. So that's again a consideration though. At-risk relatives, so I know we're doing the testing for the individual I'm meeting with, but it has implications for family members. Oftentimes we'll have a discussion on, is this something you've talked to your family about? How do you expect family members to respond to this information? Oftentimes we provide resources like a dear relative letter that family members can then share to say, here's the testing I've done, here's the finding that came back, here's what we recommend for follow-up. Uncertain results are pretty common in genetic testing. So those are cases where we do a test, we find a variant in a gene that we just don't fully understand yet today. It could be a variant that doesn't have enough research, hasn't been seen enough before by the laboratory, just doesn't have enough data and research behind it to really say for certain that it's nothing. Where we all have these benign genetic variations. They may make us who we are, so we're not clones of each other, and most of the time they don't have anything to do with cancer risk. We just don't know for certain. So those are cases where maybe a few months down the road, maybe a few years down the road, we get more data from the laboratory to say, we've seen this in families now with this specific cancer, it seems to track, we're going to upgrade it to a concerning findings. Or more likely than not, it gets downgraded, ends up being nothing. But still, there is that potential uncertainty when we're doing testing. And a big thing too is whether somebody wants to know or doesn't want to know. Is this the right time to be getting this information? I think one of the reasons why I wanted to specialize in oncology so much is that there's more we can do with this information, where if someone hasn't had cancer, it's not a cancer diagnosis. If someone has had cancer, we're trying to get actionable information to improve outcome, to provide those targeted therapies, to be proactive. Where in some areas of genetics, there's less we can do when it comes to, if you're familiar with Huntington's disease or Alzheimer's, which can be genetic, where right now there's just less interventions available, and that knowing or not knowing might be a bigger concern there, where I find with oncology, it's becoming a lot more standard just to say, it's another data point. If you're comfortable getting this information now, here's the potential benefit. So once somebody has met with a genetic counselor, potentially done genetic testing, then the question is, what do we do with this information? For most cancers, we don't do routine screening. So the main ones that I know of that we do routine screening for would be like mammograms, where we typically start at 40. It might be an annual screen. Colonoscopies now have been pushed down to start at 45. There's been a lot more data of just younger colon cancers that we're seeing. And so we start at 45 now, go every 10 years if the colonoscopy is normal. Cervical cancer, so with pap smears, that's pretty routinely screened for. Lung cancer may be screened for individuals who smoke, and then prostate cancer for some men at an older age. But what if we find a genetic risk for uterine cancer? What do we do about that? So in that case, it might be imaging. It might be an ultrasound of the uterus, or it might even be thinking about doing a hysterectomy and removing the uterus proactively so a cancer can't happen. Or if we find a genetic risk for kidney cancer, it might be, again, an ultrasound or imaging of the kidney, or maybe one of those tumors that secretes hormones. We're doing a blood test now to see if there's any signs of that tumor being present. So going back to hereditary breast and ovarian cancer, when we look at these risks, and then it's that question of what do we do about this? So when someone has an up to 70% likelihood of developing breast cancer, we recommend screening earlier and more frequent. So if I were to meet with a young woman diagnosed with a BRCA mutation, what we would recommend is starting those breast MRIs when she's in her 20s. And those would be annually until she's 30. When she's 30, then we would add a mammogram every year too. So it ends up being 2 screens each year, a mammogram and a breast MRI alternating every 6 months. Some women decide to do a more prophylactic surgery, so having a bilateral mastectomy, removing the breast tissue, which reduces that risk by over 90% for developing a breast cancer, and also eliminates the need to do all of this extra screening if someone chooses to do that. The common discussion that I would have with someone may have a BRCA mutation. For ovarian cancer, we don't have as good of early screening, and it's again not something that we routinely screen for. The only screens that we have that some may be familiar with are the CA-125, which is a blood test. Oftentimes that's done to monitor an active ovarian cancer. It's not as reliable as a screening tool because it could be low when someone has a cancer diagnosis. It could be high for other reasons like endometriosis, unrelated to ovarian cancer. Ultrasounds as well are considered, but again, they can only see what they can see. And ovarian cancer being such an aggressive cancer that it is hard to treat often if it's caught late, we recommend a risk-reducing surgery for most women. And so that's oftentimes between the ages of 35 and 45, depending on the gene. There's some data suggesting that BRCA2 tends to have later onset risk, slightly lower risk, so that conversation may start at 40. But we do recommend removal of the ovaries if there is that risk for these aggressive cancers. For prostate cancer, it's usually just prostate screening over the age of 40 for men. Pancreatic cancer is a newer screen that we've started recommending. So it might be an MRI or endoscopic ultrasound, usually done at a specialized center. So here at the University of Minnesota, we do follow patients at higher risk for pancreatic cancer and do this screening. It's ovarian where it's hard to really quantify, is there a benefit of detecting it? If we can detect it early, I think the hope is that it hasn't had the chance to spread. Treatment is better, but it's an area that it's still, I think we're still trying to find good screening for pancreatic cancer, just like ovarian. With male breast cancer, usually with that risk just being slightly elevated, we recommend clinical breast exams for men when they're 35. For some men, we do consider doing mammograms, especially if someone has gynecomastia or more breast tissue present. That's something that we would think about. Melanoma, again, these are now pretty low risks, especially if someone has any family history of skin cancer. We're going to recommend you seeing a dermatologist, getting a full skin exam, just to look for any of those atypical moles. And then I know a big area that I was asked to talk about here is a blood test that can screen for many different types of cancers. So right now there is a test on the market. It's not currently covered by insurance as far as I'm aware, but it's a blood test that you can do in clinic that screens for many different types of cancers. So this specific company claims to be able to screen for 50 or more types of cancers. The role of this screening is not to replace routine screening that you may already be doing. So we still recommend doing those annual mammograms, doing those routine colonoscopies, but now we can screen for many other types of cancers that we just don't have that routine screening for, or ones that are maybe hard to detect early, like ovarian and pancreatic cancer. So from these tests, the result that you get back are whether a cancer signal is detected or it is not detected. If the signal is detected, then the algorithm is able to predict where is that signal coming from. Is it expected to be a breast cancer origin or a pancreatic origin? And then follow-up diagnostic testing is needed to confirm. The technology used here is called cell-free DNA. So going back to just our traditional germline genetic testing, that's usually done from a blood draw. It's looking at the genes that you were born with, and those are in your white blood cells circulating, which is why we can use blood. We can also use saliva to do germline genetic testing. We can also do skin biopsies if needed. So we're just looking at the genes that you were born with. Here it's looking for small fragments of DNA that are released by cancer cells. So all cells divide, they die. When they die, they release their contents, and sometimes that includes some small fragments of DNA that can then go into the bloodstream. And so the cell-free DNA is just a very small proponent of the DNA in the bloodstream, but what we're looking for this screening. Specifically, what it's looking for is methylation patterns. So you could think of methylation on top of the DNA as the on and off switch. So if we have a gene that regulates cell division, methylation may then turn that regulation on or turn it off. And so oftentimes in cancer, that methylation, there's a specific methylation pattern where maybe it has switched that gene on and it shouldn't be on as long as it is, and that can lead to too much cell division in a cancer. And so the technology here is really looking for those specific methylation patterns that can be associated with a specific type of cancer. This is technology that has been used for many years already, many years being maybe around 5 to 10 years for prenatal testing. And so we use the same technology during early pregnancy. It's a blood test that can screen for baby circulating DNA within mom's blood. I think some important pieces here again that I just like to reiterate is that this does not diagnose cancer. It's a screening tool, just like with genetic testing, those do not diagnose cancer. And follow-up diagnostic testing is needed just to clarify, is there a cancer present? So if there is a signal for potentially breast cancer, let's go in and do that diagnostic imaging. Let's do a breast MRI and either confirm or rule out that there is a diagnosis. Does not predict future cancer risks. So that's the role of germline genetic testing more so, where we can say if someone was born with a genetic risk for cancer, here are the risks that we're dealing with. Here it's really just is a cancer signal detected or is it not? It doesn't predict all or detect the presence of all cancers either. And I think there's a next slide there on that too, where still routine screening for breast and colon cancer is the gold standard. It's still better at detecting a cancer, where now this is just casting that net wider and hopefully detecting other cancers potentially early too. False positives and false negatives are also a potential concern. False positives, not so much. False negatives, though, it's tricky just because we can't detect all cancers with all screening tools. There are going to be a proportion of people who are missed. I think that shows here too, where it looks like based on, this is data from the test called Gallery that is doing this testing currently, where they're really good at detecting liver and bile duct cancers, pancreatic cancers, ovarian are pretty good at being detected, but things like prostate, even breast, not so good at detecting those cancers. So I believe this is the sensitivity, yeah. So the proportion of individuals who have a cancer who actually tested positive based on the Gallery blood test. So the gold standard is if there are concerns, if someone has thyroid nodules, let's do an ultrasound, let's do a biopsy, where we're not going to rely on this type of screening here, or if it comes back normal, doesn't mean that someone doesn't have a cancer. I know we're kind of ending early, but I know I can always go back and talk about other points too. But I think the main takeaways here is just the role of genetic counseling in an oncology clinic, where oftentimes it might not be something that you may have heard about until your doctor refers you. I think it's becoming a lot more routine to get these referrals, especially if you've been diagnosed with a cancer, especially when we're talking about breast, ovarian, colon, pancreatic, aggressive prostate cancers. Those are typically automatic referrals to meet with genetics, or even there might be testing done by your oncologist as part of treatment. And then thinking about post-treatment too, if there's maintenance drugs that may be more beneficial, or additional screening that we should be thinking about, if there's other cancers that may be at higher risk, being able to modify those recommendations up. Also, realizing that genetic testing is limited. With germline testing, we're only detecting mutations in 5 to 10% of families. So that means most cancers, we're still left with the question of, why did this happen? Have a clear answer. It's probably a combination of a lot of things: environment, random chance, age, lifestyle can play a role. One example that I give when counseling patients is thinking of cancer like a glass of water. If we're born with an empty glass, it just takes a lifetime of risk factors that slowly accumulate over time. And it typically takes a lifetime of those risk factors for that glass to potentially overflow and for a cancer to happen. Where In contrast, if someone was born with a genetic risk for cancer, it might be that that glass was already over halfway full, and it just took less of those random risk factors to accumulate and overflow that glass, potentially even overflow a second time for other cancers too. Early detection and prevention is key. So the goal here in oncology is identifying those individuals who may be at higher risk for cancer, knowing that routine screening is not appropriate for everyone. This is all based on population data. What is the benefit for most people in the general population, which is like those mammograms, colonoscopies at 45, going every 10 years. But if we identify someone is at higher risk, whether it's based on family history, the polyps that they've had, their genetic testing, we can make more individualized recommendations for that person. So even if thinking about colon cancer, which is a common one, if someone has a parent who is diagnosed with colon cancer, we typically recommend starting 10 years prior to their diagnosis for screening, or 45, which is now the standard age. And then we go 5 years in between. Actually, we start at 40 and then go 5 years in between each screen instead of waiting 10 years. So even without genetic testing, sometimes genetic counselors can make those recommendations based on family history alone. Similar with melanoma. If you have a close relative with melanoma, I would recommend seeing a dermatologist just because there could be shared environmental factors, shared genetic factors with your siblings, parents, children, if they have melanoma that may also put you at higher risk. Everything I had, but I'm happy to go back if there were areas that there were questions on.
Yes, Alyssa, thank you so much. If you want to, I guess I will leave the slides up in case we want to jump back to that. We do have a couple of questions that both came in the Q&A and as well as the chat. And I want to invite the other folks to please use this time now to enter your questions. I do want to let the audience know that we will have a survey that's going to be emailed to you tonight. So please do take a chance to complete that survey as soon as you get it. You also get a chance to win a swag bag with your response. So as those other comments and questions are coming in, we do have a couple of other questions that came directly. And the first question is, what about twin sisters? So this question is stating that one child was diagnosed with Hodgkin's lymphoma in 2020, and she's got an identical twin. Is there increased risk of cancer for the twin sister?
Yes, and I'm glad that question was sent ahead of time too. I was able to look at some papers, or oftentimes for specific relative risks or odd ratios, we go back to the research where it's tricky with lymphoma. If we don't know why the lymphoma happened for the one sister, and we just have no idea, we would assume there may be shared genetic and environmental components. The data I found for Hodgkin's lymphoma, the general population risk is about 0.2%. So Hodgkin's lymphoma is quite rare. If you have a first-degree relative diagnosed with Hodgkin's lymphoma, you're at about a 3 times elevated risk. So I think that data shows that there could be potentially a shared genetic component. But still, if you do the math, that risk ends up being, if I did it right, about 0.6%. So, and that'd be for a first-degree relative. Obviously, if they're identical twins, that risk might be slightly higher. But still, it's tricky with lymphomas where we don't have enough data to really say, is there screening that's beneficial to do in those cases? But I think there is evidence to support that there could be a shared genetic component without knowing what caused the one individual's cancer. So we just have to assume that there could be other things.
Great, thank you. Could you comment on the difference between getting a blood test versus doing one that comes commercially using saliva, et cetera, like 23andMe? Yes, please.
Yeah, so I think there's 2 parts there. One thing I get asked a lot about, well, is saliva just as accurate as blood? And the answer is typically yes. Something that we've been implementing a lot more during COVID is obviously these virtual visits, but also having saliva kits mailed to someone's house. So a lot of the commercial laboratories that we do the genetic testing through can send a saliva kit directly to the patient, spit in a tube, send it back. It's the same quality of clinical genetic testing. But that is different than 23andMe, which is using a different testing technology than the technology we're using in an oncology clinic. So the main difference is when I order a genetic test, we are doing a full analysis of most of these genes. So for instance, the BRCA genes, we are doing sequencing, which is reading through every nucleotide that is in the coding region, looking for any misspellings or mutations, as well as missing and extra pieces of DNA. Where 23andMe is just looking at specific variants. So for instance, 23andMe does include the BRCA genes, but only the 3 founder Ashkenazi Jewish variants. So if you are not Ashkenazi Jewish, it is not helpful at all to do that testing. If you are Ashkenazi Jewish, it may come up through that testing, but I'd still want to validate it through our full sequencing and deletion duplication analysis, since it is using a different technology. And I know the 23andMe's also do Ancestry, which we don't do clinically, but I consider that more recreational genetic testing, where if you have the $200 or $300 to do the testing and are curious, it'll probably tell you what you already know. Maybe it'll connect you with relatives you didn't realize that you had, and there's certainly implications there. More and more, they're including health information too. So I know like the BRCA 3 founder mutations are now included. Likelihood to have dimples, likelihood to have freckles, kind of more of those recreational tests. Some medical implications like carrier screening. Again, I would validate any of that testing though through a clinical lab, so I wouldn't rely on 23andMe alone.
Great, thank you. This question is wondering how frequently, if a patient had genetic testing done, say 5 years ago, 10 years ago, or even 2 years ago, how frequently should they retest?
I think it really depends on the testing that was done. So with the BRCA genes or for breast cancer, it's pretty common for me to see someone who was maybe diagnosed 20 years ago with a breast cancer, had genetic testing done at that time, which was just the BRCA genes, since that's all we were testing for at that point, and are being referred back to do these more expanded panels. So I can say at the very least, 2013 is one of those cutoffs where if you had testing before then, I would double check and see what was really included. Was it just the BRCA genes, or were they doing any panels at that time, since panels became more common after 2013? And even after that, there's been new genes added, testing technology updates where earlier BRCA testing was missing 10% of mutations, and now we're retesting in those cases and sometimes finding a previously unidentified mutation. And the newer genes that are discovered, the genes that have now medical management guidelines that we didn't know about before. We used to say 5 years to follow up, though that was a few years ago when it was around that 2013 timeframe. Usually what I tell my patients is it doesn't hurt just to follow up, especially if there's updates to family history that might update the testing that we would want to recommend. So I wish I had a clear cut 2 years. That's how quickly we're getting new information. There could be a big advancement next year that changes the testing we're ordering. The last few years have been pretty stable, where there haven't been big advancements. Obviously, some panels there have been new genes included, some prostate cancer genes, lymphoma and leukemia we've been testing for now more, but it's really dependent on the cancer type.
Yeah, so tagging into that, is there anything about genetic testing for bladder cancer that you know of?
Yeah, typically bladder cancer isn't inherited. Oftentimes it has an environmental component. So what I may ask someone who's been diagnosed with bladder cancer is, did they have a history of smoking? Any sort of environmental or occupational exposures, like being a truck driver and having a lot of that exhaust exposure. There are some genes that can overlap with the urinary tract. And so if the personal histories may be significant with a very early onset bladder cancer, and we're also seeing family history, maybe colon cancer and uterine cancer in the family. It could start to form a pattern. I'd say bladder cancer by itself, usually not overly concerning. Once we start seeing those patterns, I may start thinking about Lynch syndrome, which is a group of genes associated with high risks for colon cancer, gynecologic cancer, GI tract cancer, lots of extra screening that we would recommend. Can sometimes see with bladder cancer.
If you could, since you've got this slide up here, there is a question, just what is a familial cancer? If you could restate, so there's a question, what is familial cancer? And then what are the differences between hereditary versus sporadic mutation? So
Yes, I get
I can ask that second one again, but starting with what is a familial cancer by definition?
Yeah, so there's two ways to diagnose a familial cancer. One is through genetic testing. So these are the 5 to 10% of families where we do genetic testing and we find a single gene, a mutation in a gene associated with that cancer. So in the case for breast cancer, a familial cancer would be someone who has a BRCA mutation, where we know they were born with that genetic risk. That's a genetic risk that can be passed on to somebody's children and was likely inherited from one of their parents. And so then there's follow-up testing that we can recommend. Because that mutation was present at birth, it's in all of somebody's cells. And so it doesn't just impact breast cancer risk, it also impacts ovarian cancer, prostate, male breast, pancreatic potentially. So there may be a constellation of risks that we would be concerned about versus someone who has a sporadic cancer. So a sporadic cancer seems to occur randomly, typically as we age. So one example is skin cancer. Most skin cancers are sporadic. They may happen due to UV exposure. That UV exposure is actually causing DNA damage at the cellular level in that spot in the skin. And with enough damage, and if we're not able to repair that damage, it has the potential to turn into cancer. You weren't born with that damage. You weren't born with those genetic changes. They happen because of an external force and random chance and potentially other factors too.
Excellent explanation. So now here's a kind of a case application. So a parent had a colon cancer, but the screening revealed non-hereditary mutation. Is that child then at a higher risk for colon cancer?
Yeah, so say if someone's parent did genetic testing and it came back normal, so that parent had a panel of genes done, it's up to today's standards, it included Lynch syndrome, it included all the genes that could potentially provide answers. This is a situation we run into a lot where we come back with nothing. Most of the time we get normal results in genetic testing, and so then the family members are now wondering, well, my mom or my dad had cancer. We don't know why it happened. Maybe it was just random and at an older age, but what is my risk? And that's where we can sometimes make recommendations. So in that case, if a parent has had colon cancer, let's say they were diagnosed when they were 45, no genetic mutations found. For their kids, we would recommend starting colonoscopies at 35, just because there still might be that familial component that we don't have a test for today. There could still be shared genetics, shared environmental factors that we just can't quantify, at least today. Maybe in a few years we'll have a risk model that can estimate that, but right now we just say start 10 years earlier. Let's go every 5 years instead of 10 years for your colonoscopies, just to be a bit more proactive. So similar to the case where a sister may have a lymphoma, we would say, well, probably at a little bit of a higher risk, but then it depends on the cancer type. And if we have clear recommendations to say, here's what we should do, is there a benefit to address that risk? For lymphoma, possibly not. For colon cancer, I think we have more standards.
Great, thank you. So just one more clarification around this. Is hereditary cancer different than familial cancer?
Right. So, and this is where sometimes these pie charts, I hesitate to put them up because there's a lot of gray areas in genetics. I think the main takeaway here is that the vast majority of the time, most people aren't born with those genetic risks. Most of the time, those genetic risks aren't inherited in a family as a single gene, like the BRCA genes. But there are those families, so that 15 to 20% here, where we do genetic testing, it comes back normal, but there's still concern. Maybe mom, aunt, grandpa have all had colon cancer, early ages, they've done testing, it's normal. Maybe it's a gene we haven't discovered yet. So I think that category is where we start thinking about a parent has had a cancer, we don't have a clear answer why. There could be shared genetic and environmental components there. It's just we don't have a clear genetic test for that familial piece versus a single genetic risk factor that has more of a significant implication for care.
Mhm. And this question is about the CA. It does say 127, but I believe that's CA 125. And how reliable is that?
Yeah, so oftentimes I recommend someone talking to their gynecologist about that screening. It's not a standard of care for at-risk individuals, so individuals who haven't had an ovarian cancer. I know there are some trials going on, potentially at the Mayo Clinic, that's looking at more frequent sequential CA-125s to get more data points and looking at those trends potentially, where if it starts to trend up, then there is that clinical concern, could there be an ovarian cancer present? I think just because of how aggressive ovarian cancer is and how hard it is to detect early, that's why we typically take those bigger proactive measures if someone does have a significant risk. Run into problems though where we don't have clear recommendations is that familial category. So let's say someone has a mom who had ovarian cancer, she did genetic testing, it's normal, could just be that that was a random cancer that happened, but daughters may still have a slightly elevated risk. So instead of being at a 1 to 2% risk, she may be at a 7 to 9% risk. But what do we do with that information? We don't really have clear guidelines to say we should do a surgery, we should do screening. So it does become a bit more uncertain.
We are at 6:50, just wanting to do a time check for everyone. If you have any additional questions, I think I have 2 left here, but please get those in the next couple of minutes. So this question is asking about skipping generations. So this woman has a metastatic breast cancer diagnosis at age 56. When should the granddaughter start testing? She's 2 now, jumping the gun, but just curious. And there is a familial component, great aunts with breast cancer. So just the immediate parent-child relationship we talked about, but now what about grandparent to grandchild?
Yeah, so from a genetic testing standpoint, I usually recommend testing to start with the individual who's had a cancer, who's most likely to have a potential genetic risk. So that's addressing that 5 to 10% hereditary component. If that comes back normal, now we're potentially into that familial component where there's a strong family history, no clear answer, and female relatives could be at risk. So usually what I recommend for, say, a second-degree relative, like a grandchild, is we start 10 years younger than the earliest breast cancer in the family. So that might be starting at 40 for her mammogram, so a long ways down the road. We likely wouldn't recommend any genetic testing if the affected individuals have already tested normal, but it might be when your granddaughter is getting close to starting screening, we'll run a risk model that incorporates hormone factors. When did she have her first period? Does she have biological children? Has she gone through menopause? Family history, all of those things can play a role in a woman's breast cancer risk. And sometimes we can estimate, is that risk high enough that we should add maybe a breast MRI along with her mammogram each year?
Great, thank you. Last question, this is specific to micrometastatic disease. Is there any sort of blood test? I think this maybe takes on to the gallery testing earlier. Just if somebody has micrometastatic, are there blood tests that would pick that up?
I am not as familiar there. That would be an oncologist ordering that testing. For gallery, I do know that it is not recommended if someone has an active cancer diagnosis that they know of already. So it's not recommended in those cases or with metastatic disease, since we know that that DNA in those cells would be circulating.
Great. Thank you so much. A lot of questions. Thank you all for submitting. And Alyssa, great job at answering these. I'm just going to check one last time to make sure we caught everything. Otherwise, let us, I'm going to turn it over to Alyssa here to wrap up. Again, Alyssa, thank you so much for sharing both your time and expertise with us. I've really learned a lot tonight, and I really appreciate you joining us tonight.
I know it's a lot of information oftentimes when it comes to genetics. Anytime I meet with a patient, we go through all of this information within about 45 minutes. So you can expect this is kind of the education that I typically provide on a daily basis. And I think it's just helpful, even if you're not interested in meeting with genetics, knowing that it's an available service. And for some families, it is an important tool.
Absolutely. Well, thank you so much again. I also learned a whole ton. And for anyone who maybe wants to rewatch or who joined us late, a recording will be available on the website by the end of this week. And as Kaya mentioned earlier, tonight you'll also receive an email with a quick survey to help us continuously improve our programs. And then, of course, you'll be entered to win a swag bag of fun stuff for completing that. We look forward to seeing you next week, and I'm going to drop a link in the chat right now. If you're not already registered, you can register for our upcoming sessions there. We would love to see you. And next week, we are delighted to hear from Jeff Pounds, who is one of our oncology psychologists, who will be talking about the mental health impacts of a cancer diagnosis and treatment. So we look forward to seeing you then. Thank you again, everyone. Have a wonderful night.